At Community Medical Center, what I'll call CMC, 2 types of patients are sent to diagnostic departments for procedures. They are outpatients and inpatients. The outpatients come to the hospital, register, complete their procedure, and leave on the same day. The inpatients reside in the clinical departments overnight and are sent to diagnostic departments for various procedures, depending on their medical necessity. Once that procedure is complete, they are returned to the clinical department. Some of the outpatients who come for procedures are frail and old and therefore unable to walk to the diagnostic department. Therefore, it's the responsibility of the transportation department to provide a transporter to transport the patient to the appropriate department for procedures. Similarly, it is the responsibility of the transporter to transport the inpatients to the diagnostic department from the clinical departments when they are scheduled for a procedure. The diagnostic departments, and there are many of them, the operating room, radiology, nuclear medicine, cardiology, endoscopy, and the emergency room. Within CMC, these departments regularly complained that the patient transporters took an exceedingly long time. This caused delays in treatment and patient waits, and they blamed the transporters for those delays. Many thought that the transporters were having long coffee breaks and weren't doing their job. They sometimes called the manager of transportation and complained. They would say, "We called 35 minutes ago, and the patient's not here yet." The transportation manager became exasperated with the influx of complaints and wanted to analyze the problem. So a group of individuals representing the various diagnostic departments, again, like radiology, endoscopy, special procedures, cardiology, nursing, transportation, and quality risk management. They all met to discuss this issue. To understand the problem firsthand, the transportation manager and 4 transporters observed their current process. They observed the patient request to transportation process as it unfolded every day for 10 hours for 10 days. He also contacted and interviewed different individuals in the diagnostic departments and in the clinical departments as well to get first-hand information about the process. The transportation manager said, "We observed all nursing stations and procedure areas and noted a process full of miscommunications. For example, I observed the ward secretary. She said she would call a transporter right away. She actually made the call 37 minutes later, 3 minutes before the procedure. This happened frequently. The procedure department and the nursing station never communicated as to the expected patient transport time or procedure times. The patient's nurse often did not know the patient was going to a procedure. So the patient's medications were not always met in time for the procedure to happen. In addition, using a self-devised form, the manager of transportation completed a patient transportation survey. In his survey, he measured the time difference between the transporters receiving a beep which was a request from the diagnostic department, to the time the patient was transported to the diagnostic department or the procedure area. The results of 23 patients surveyed over a 3-day period, this was from January 15th to January 17th, 2003, showed an average request to delivery time of 56 minutes. The actual patient transport time was only 5 minutes, and the rest of the time was preparation time and delays in communication. The communication delays caused delays in timely procedures, resulting in unhappy patients, clinical workers, and physicians. In the current state, somebody from the diagnostic department, usually a technician, called or paged the transporter. At other times, somebody from the diagnostic department called the ward secretary on the floors, who then called the RN and then the transporter. The transporter did not know who was paging. Sometimes the message the transporter received said, "Bring down John Doe to radiology." There was no information on the room number, the bed number, the floor, or the area. The transporter did not know from where the person was paging and did not always know whom to call to clarify. She only knew a patient needed to be transported. A great deal of time was thus expended by the transporter on patient search. If the information was complete and the patient was ready for the procedure, the transporter reached the patient and transported him or her to the diagnostic department. However, in many situations, when the transporter reached the patient, usually inpatients, they weren't ready. They might have been in need of medication or a magnetic resonance imaging (MRI) screen, the bathroom, IV changes, or other needs. In those situations, as the patient was not ready for transport, the transporter contacted the nurse. The transporter left the room and waited for the call from the nurse when the patient was ready for the procedure. The transportation manager recorded the patient-ready transportation time and obtained the shortest 9 minutes, the longest 177 minutes, and the average transportation time about 56 minutes from the data collected earlier. When asked, the problems he identified were no written message to request a transporter and late arrival by the patients to their diagnostic departments. The team brainstormed the root causes to the problems using the 5 whys approach. The analysis revealed that the staff members calling from the diagnostic department were often too busy to send written messages to the transporter or to the floors, and therefore the message lacked complete information, causing delays. Additionally, RNs or the ward secretaries were sometimes not aware that a patient needed a procedure, and therefore they failed to prepare the patient on time, which eventually led to late arrival of the patient at the diagnostic department.